Hello, everyone, and welcome to episode 36 of the Dysphagia Matters podcast. My name is Jule, and I am here with Julia.
Hi, everyone. So, we wanted to take the time and announce that we have now reached more than 3,000 listeners of our podcast. So, thank you, everyone, for tuning in.
Yes, that is so great. Thank you so much for listening and also for following on our social media accounts. It is so cool to see how this little dysphagia community is growing. So, thank you so much for your support.
So, we also wanted to take the opportunity to reintroduce ourselves so that you actually have an idea about who you are listening to. Jule, do you want to start? I think you have some big news to share.
Okay, so I finally started my PhD in the field of neurogenic dysphagia and endoscopic evaluation in Düsseldorf in Germany. And yeah, it took me a few years to get to this point, to find this opportunity and funding, and I'm just very happy and excited that it is finally happening now.
Yes, absolutely. So, congratulations again. And I hope that this also encourages listeners to be persistent if they are interested in doing a PhD. I think it's definitely worth it.
Yes, thank you. So what about you?
Yeah, I'm in my last year of my PhD in Dublin, in Ireland now. And for the PhD, I developed a core outcome set for dysphagia interventions in Parkinson's disease. And if you're not familiar with core outcome sets, no problem. We have an episode, we have you covered. So I highly recommend listening to episode 14.
Yes, absolutely.
And now back to today's episode.
So one of our listeners, Rachel Coates, reached out to us and suggested the topic of pharyngeal electrical stimulation. And we thought that since she is working clinically with this treatment approach, she would be the perfect guest to share her clinical experience with this.
In this episode, Rachel shares her insights on how PES works, the benefits and challenges of using this treatment, and also her advice for clinicians considering integrating PES into their practice. So enjoy listening. Hello, Rachel, and welcome to the Dysphagia Matters podcast. We're happy to have you with us today. Maybe to begin with, could you briefly introduce yourself?
Hi, thanks for having me on the podcast. I'm absolutely delighted to be chatting to you both today. So, yeah, my name's Rachel Coates. I'm a clinical specialist speech and language therapist at the Mater Hospital in Dublin, and I work primarily in stroke. I'd also just like to say that I'm not in any way affiliated with the company. Kind of everything I say to you today is based on my own clinical experience and what I know from the research. I'm not getting any kind of financial benefit from talking to you about it.
Hi, Rachel. It's nice to have you with us today. In our last episode, we talked about the development and the research that supports the effectiveness of pharyngeal electrical stimulation. And today we would like to talk to you about your experience of using PES in clinical practice. But before we do that, just a short information for our listeners. PES and PES are just different ways of pronouncing the same abbreviation. So we're talking about the same thing with these two words. So let's start. Why did you become interested in PES?
So I became interested a number of years before actually starting to use it in clinical practice. So I'd read some of the research papers. I was definitely intrigued and excited. And we had the rep at the time come and talk to the SLT team that I was working in about the treatment. It seemed really positive, but it wasn't really being used in clinical practice in the UK at the time. I think Sarah Wallace and her team in Manchester had just started using it, and they were kind of really the only ones. And it wasn't until a year or two later when I met a patient called Tony that I first used it in clinical practice. And I think we've all had patients like Tony from time to time, like the ones with really, really severe dysphagia. And it's just not improving despite all of your best efforts. And we really just kind of feel a bit useless in these cases. All Tony wanted was to be able to eat and drink, and I just couldn't make that happen for him. And I think you just sometimes just wish you had like a magic wand. And I really feel that PES is that magic wand. So Tony is really delighted for me to share his story with you. He's really pleased that the treatment that he benefited from 4 years ago is now being used more routinely. So I was working at the time in the UK in an NHS hospital. So it was 2020, height of the pandemic. And he was among the first kind of handful of patients in the UK to be treated with PES. So a little bit of background on him. So at the time, he was 55 years old. He was admitted to hospital in September 2020 with a large right MCA infarct. He presented with left hemiparesis, dysarthria, and his biggest concern was his dysphagia. So he was transferred to our stroke rehab unit and then to our complex rehab unit. And he ended up being in hospital for like a really extended period of rehab. So a month into his admission, he'd been making slow but steady progress with his swallowing. He was having some SLT-led oral trials, I think with like level 2 fluids, level 4 diet. A month after admission, he had a hemorrhagic transformation, shortly followed by COVID. And these two things completely shattered the progress that he'd made. He was back to being nil by mouth, and he'd had multiple FEES examinations. They showed really poor secretion management. He was pretty much kind of aphagic, really struggling to elicit a swallow, high risk of aspiration on his own secretions, and PAS score of 8 on all consistencies trialed. So I think I was conducting probably 4th or 5th FEES with him, and I was just giving him the really bad news that there'd been no change in his swallow presentation, despite all the effort that he'd been putting into his dysphagia therapy. He was desperate to be able to eat and drink again, and I still remember him. He like reached out for my hand, and he was like, "Please, is there anything?" He was like, "I would literally try anything." He's like, "I need to be able to eat and drink again." He was desperate. So I told him that I'd heard of a treatment called PES, kind of explained to him a little bit about my understanding of it at the time, which was quite limited. I said I wasn't sure whether he would be a candidate for PES and that we didn't have it available in our hospital, but I was like, leave it with me. I'll see what I can find out. I was kind of in my head thinking at that time that maybe he would kind of leave hospital with a PEG and this might be a treatment that he might be able to access in the future. So I then got in touch with the company and chatted through his case with the then rep. And she felt that he would be a really, really good candidate. And she offered to come to the hospital, set up the treatment for him, which was like really, really exciting. So I had a few hoops to jump through first in terms of getting approval for it to be used in our hospital site. So it took about a month for me to get all the relevant permissions from New Devices Committee, ethics, clinical engineering, like the consultants, have everyone on board. So 3.5 months after admission and being mostly nil by mouth for that time, we were able to get going with the treatment. So on the day that the rep came in and came and set everything up for us, I repeated the FEES to make sure there'd been no spontaneous recovery in that time and just make sure that the treatment was still indicated. We inserted the catheter and kind of started straight away with the treatment. And I remember the rep telling him she was sure that this would work for him and that he'd be able to eat and drink again. I was taken aback, I think, slightly, because I don't tend to tell patients that their swallowing will definitely like get better, especially like this kind of cohort with such severe dysphagia. So anyway, by day 2 of the treatment, he told me he was able to feel electrical impulses in his throat. And I was noticing he was triggering lots and lots of swallows during the treatment. So he was sure it was working. He may well have been doing lots of swallows during the first treatment, but I think on the first day I was so concerned by like pressing the right buttons and everything that I wasn't really like paying attention. So after a couple of days, he was able to feel the tube in his throat. So we did the treatment Monday, Tuesday, Wednesday, and then I can't remember whether it was Thursday or Friday that I did his repeat FEES. So passed the scope, had a look. There was improvement in his secretion management, but he was still really high risk on oral intake. So a patient was really deflated, like I was deflated, kind of really, really disappointed, kind of felt like this treatment that we'd pinned all our hopes on just hadn't worked. So I spoke to the rep and she was like, oh no, like just give it a bit more time, maybe repeat the FEES on Monday. Sometimes the effects of the treatment are a little bit delayed. So I wasn't overly optimistic, but I agreed to repeat the FEES on the Monday. Went back in a few days later, it felt like the longest weekend ever. On the fees, I could not believe the change in his swallow status. He was now able to safely manage level 0 fluids and level 6 soft and bite-sized diet. He was over the moon. Like, I couldn't believe it. So we did a further 3 days of treatment and he was upgraded to regular diet. We also kind of focused on the oral stage of swallowing as well. I guess like my mind was just blown. I'd never seen anything like that before. And like, it was definitely not spontaneous recovery after that length of time with no change. And then the only kind of variable then was this pharyngeal electrical stimulation. So yeah, I didn't want to stop there. I went back to the New Devices Committee, all the relevant people, and requested permission to continue trialing this with other suitable patients.
What a wonderful story. Thank you for sharing that. For how long have you been using PES in clinical practice now, or how many patients have you used it with, and what's your caseload like?
Yeah, so I've been using it obviously since working with Tony, so 4 years now, and I've treated 15 patients. So I think it probably would be more, but I haven't been working all of that time. Like in that time, I've had a baby, moved countries, and broken a few limbs. So yeah, I've moved over to Ireland and I'm now working at the Mater Hospital in Dublin. I was really, really keen to implement PES as part of our clinical practice when I started in my new role. And fortunately for me, everyone was on board with it. So I presented the research and my experience with PES to the SLT team, the stroke team, clinical engineering, basically anyone who would listen. And then we purchased an evaluation pack in October last year. So it was a particularly busy time for us. Like we had 6 inpatients at the time who were all really suitable candidates for PES. So like we really, really kind of hurried to get the equipment on site. So we don't normally treat kind of that number of patients at once. We're normally only ever treating kind of 1 patient at a time, maybe 2. So I worked out as part of our business case at the Mater that we would likely treat 12 patients a year in stroke using PES. So I calculated that by looking at the previous 6 months of data and establishing how many patients would have been suitable if we'd had the treatment available. And this figure kind of matched with what the literature tells us about the incidence and prevalence of dysphagia post-stroke. So I was quite happy with that. We've also requested some additional catheters for use in other areas, such as critical care. We also have like National Spinal Injury Unit and a major trauma centre for Ireland. So this treatment is for those with kind of a severe sensory dysphagia. They're the ones that kind of aren't resolving kind of on their own. The ones that are kind of typically with us for kind of quite a long period of time. Their admissions often complicated by recurrent pneumonias, and like we struggle to find kind of rehab settings for these patients that accept NG tubes. So they're quite a complex kind of cohort of patients. We're anticipating needing more catheters in the future, obviously, with the number of strokes expected to rise as a result of kind of aging population, lifestyles, and more people than ever surviving strokes.
Yeah, thank you. And can I ask what time approximately post-stroke you would usually start with the PES treatment?
I'd say sooner is better. It's really important to kind of get in and kind of assess, like ideally with instrumental, and then start treating early on, like before the complications of dysphagia become apparent. So before they're starting to kind of develop pneumonia and things like that. That said, I have actually heard case studies of patients being treated kind of 10 years after onset of dysphagia and still having like really incredible results.
Yeah, 10 years post-stroke, you probably don't talk about spontaneous recovery then.
Yeah.
Most likely related to the treatment.
Yeah.
So can you maybe describe the typical process of how you would administer PES to a patient in your clinical practice?
Yeah, of course. So once you've established that the patient is suitable for PES, there aren't any contraindications, there's like a few things you need to be mindful of, such as if they've got any kind of battery-operated devices like a pacemaker, cochlear implants, things like that, and it's not MRI compatible. So you need to make sure they're not having an MRI in the period while the catheter is in situ. So after that, it's pretty straightforward. So the first step is inserting the catheter. So it's also an NG tube. It has electrodes that need to be placed at level kind of C3, C4. So in our hospital, the catheter placement is done by a doctor or nurse or just anyone who's trained to insert NG tubes. I usually go along for the first session and just kind of make sure it goes smoothly, explain to whoever's inserting it, because most of the time they haven't seen this before. So explain to them that it's slightly different, it's a little bit more rigid, show them the electrodes, explain where that needs to kind of be sat. And then also you have to kind of extend the catheter slightly after taking the NEX measurement and then clamp it to make sure it stays in the right position. And then obviously make sure that we're able to see the green rings and that it's positioned correctly.
I can imagine that oftentimes patients already have an NG tube. So would you just take out the NG tube and insert the catheter?
Yes, exactly. Yeah, you just take out their regular NG tube and replace it. This is a standard kind of end-fit connection, and it can be used with the feeds that we have. So once the catheter is in situ, you then you follow your hospital's policy on checking the position of the NG tube, whether this is a chest X-ray or taking a pH aspirate. And then once it's confirmed, you can remove the guide wire, which is kind of situated in the NG part, and then it's ready to be used for feeding and for treatment. So sessions are carried out by SLTs who are trained in administering PES, and we've also trained our SLT assistant, which is really useful. Each session is 10 minutes and you can use it for up to 6 days. You start by getting the patient in the correct position. So you want them to be 45 degrees in bed, and this is so that gravity kind of allows contact of the electrodes with the posterior pharyngeal wall. But if you do lose contact at any point, the machine does kind of pick up on that and lets you know, so you can reposition the patient if you need to. You then plug in the base station, log in and connect the base station to the catheter. And then you kind of just follow the instructions on screen. So you have to make sure the catheter's in the correct position for every treatment. So if you can see the green rings in the oropharynx, then that means that the electrodes are kind of at the C3, C4 level where we want them. And then you begin to calibrate the dosage, which is individualized to each patient. So the maximum dosage that the machine delivers is 50 milliamps, but the treatment wouldn't necessarily be delivered at this level. You first of all check the patient's threshold. So you ask them when they start to be able to feel the stimulation. And I find this is quite tricky on day one because they don't really know what they're kind of looking out for. They don't really know what to expect. So 3 times you ask them to tell you when they start to be able to feel the stimulation. After that, you check their tolerance level. So you keep going up in increments and you're asking the patient to tell you, okay, now that's as much as I can manage. Usually at the very beginning, they're going really high with these doses because their sensation is really, really impaired. The machine does some calculations where it calculates the optimal treatment dose, and that's roughly 75% of the difference between the two figures, so the threshold and the tolerance level. You press a button and the machine gives this stimulation level for 8 seconds, and you can ask the patient, can you tolerate that for 10 minutes? They'll say yes or no. Sometimes I have patients go, nope, I can go higher, which is great. So yeah, that 8 seconds is kind of a little snapshot for the patient to decide whether they can manage it. If they can, you just press the button and the machine starts delivering the stimulation. And then for the 10 minutes, I would usually either just chat with the patient, sometimes play some music, put the TV on, things like that. I know Sarah Wallace sometimes talks about doing other therapy while she's doing the electrical stimulation. I do obviously use other traditional therapy alongside PES, but I would tend to do it in the same session, not necessarily during the treatment. In my experience, there's usually some positive signs within the first few minutes of starting the treatment. So they're suddenly triggering lots and lots of swallows, which they probably weren't doing before. And then within a day or two, the signs of managing secretions a bit better. They become more sensate to the catheter being in situ. And I've also noticed when doing fees, they're more sensate to the scope as well. After we've completed the treatment, we usually wait now 4 days before doing the instrumental. And I think that's just kind of what I found from experience is kind of the optimal time to repeat the instrumental assessment. 3 treatments is classed as 1 cycle, and then 6 treatments is your second cycle. We tend to do the 6 treatments as standard, and it's mainly because I've just found that most patients do need that. So it saves us needing to do an instrumental kind of in the middle of treatment. But I think if there were really strong clinical indicators, then we probably would just stop at 3. So if the tolerance levels were really, really low, the patient was feeling like their swallow sensation was restored, or like then we'd probably just do the 3 and keep the catheter in so that we still have it if needed, but do the instrumental after 1 cycle. So yeah, that's how we administer it.
Would you do the 6 sessions on consecutive days, or because you just referred to 2 cycles, is it like 1 cycle, 1 week, next cycle, second week?
Yeah, you can do, but we currently work 5 days a week, so we have to split the cycles across 2 weeks. So typically, like it's not always these particular days, but typically we would do kind of Monday, Tuesday, Wednesday, and then Monday, Tuesday, Wednesday, and then book the patient in for their fees or video fluoroscopy the following Monday. Like I think if we had kind of 6 or 7 day working, we could well just provide the treatment across the 6 continuous days.
So it probably doesn't make a difference in the effects that you would get, but basically it's just organizational things.
Yeah.
Okay. Earlier you said, so it's delivered by SLTs who are trained. I was wondering who delivers the training. You probably trained the SLT assistant, but you were trained then by the company?
Yeah, so the company deliver all of the training to everybody, and I think they have like a database that they keep track of kind of who's trained. I did my training kind of 4 years ago when I started to use it, and then just did a little refresher recently. But I think once you like order an evaluation pack or purchase kind of the full kind of equipment, the training is then just provided by the company as much as is needed. So whenever you get new team members in, they're always really happy and accommodating with the training to come over and train new people.
And based on your clinical experience, what are the benefits of using PES compared to other dysphagia treatment methods?
I guess that's what's so exciting about this treatment is that there isn't anything else out there like to compare it to. Like it really is revolutionary. Like I'm trying to think back to what I would have used prior to having kind of PES in my toolbox, and I guess there'd have been a lot of experimenting with temperatures and strong flavors in an attempt to elicit a sensory response, and probably a lot of kind of watching and waiting, but nothing that would have kind of had this kind of impact that I can kind of really compare it to. I know I keep talking about this being for sensory dysphagia, which it is, and often like sensory and motor kind of co-occur. So like if you're not getting the sensory signals to the brain, you're not going to be able to elicit a swallow. So although this treatment is for sensory dysphagia, I have also seen positive effects on like the motor aspects of swallowing, which it makes sense. Like we know that sensory drives motor. So the patients tend to swallow continuously during the treatment. And I think that in itself is really, really useful for kind of strengthening the swallow muscles, particularly in patients who have been nil by mouth for a while, and like maybe the swallow muscles have become deconditioned.
Also kind of based on the principles of neuroplasticity, use it or lose it, use it and improve it. So just through the fact of being stimulated and eliciting more and more swallows, that's already kind of a motor task and training.
Exactly.
Great. Have you experienced any challenges or limitations while using PES in clinical practice?
Yeah, that's a really good question. And I think there's always challenges, I think, when you're trying to implement something new.
Yeah, probably.
So I think there's some kind of maybe organizational issues that might be challenging, like some places are kind of resistant to change. And I think one thing that's really kind of important is getting support of kind of key stakeholders in the organization. So I've been really, really lucky in the matter in that I've had like really, really good support from our amazing stroke consultants, from my manager, and also Andrew, who's our head of clinical engineering, who has been absolutely instrumental in getting the business case kind of over the line. And then other challenges, I guess, like the current economical situation, like worldwide, like there's lots and lots of clinical areas that are kind of having advancements in their practice and they're wanting to spend money to improve patient care. So I guess it's really kind of important to be an advocate and be really passionate about it. Like with this treatment, you have to spend money to save money. And a lot of places are kind of looking for immediate cost savings. So if anyone is kind of looking to put in a business case, there's some really useful calculations completed by Health Innovation Manchester. So they've created a return on investment model. where they've used the data from research and estimated like what the savings could be from this treatment. And that's in terms of kind of length of hospital stay, reduction in pneumonia rates. So if anyone is kind of looking for any information on that to support with their business case, like I'm happy to send that on.
Yeah, we can just put it in the show notes.
Oh, perfect. So I think I use this as part of our business case at the Matter. And I think if we were to assume that those calculations are applicable to us, which they probably would be, then based on treating 12 patients over a year, we can estimate kind of savings of €265,000, which is a huge return like on the investment. Other challenges, I guess, from more of like a practical kind of considerations, I haven't really had any major issues. I guess one thing would be the catheter can fall out sometimes, like it's heavier than a normal NG tube. So in the pack, you get like a little clip with a safety pin on to help clip it onto the patient's clothes, but I still feel like it can still come out. We often bridle them, but not always. But just making sure that it's really kind of securely like fastened, like well taped onto the nose and things to avoid that falling out. Because obviously they're single patient use, and like once it comes out, you can't really put it back in again. And then I guess also it's important to make sure that the patient is going to remain in hospital for the duration of the treatment. Like we're a busy kind of acute hospital and there's a lot of movement. So it's just getting that confirmation from the consultant that the patient isn't going anywhere while we have the catheter in. And also that they're not due to have an MRI scan while the catheter's in. Yeah, patient selection is really, really crucial. So I think if you treat everybody in the hospital who's nil by mouth, you're not going to get the best kind of overall outcomes. You really, really need to look at the etiology of the dysphagia and the characteristics when choosing who to treat.
So who do you choose to treat? What are the characteristics of dysphagia?
So I work in stroke, but I have also we've been involved in trialing it on our spinal unit and also some crit care HDU patients. So I would choose to treat the people with a new severe sensory dysphagia, people that have a good baseline. They're really good kind of rehab candidates, excluding people who have other factors impacting on their swallowing. So maybe really severe oral stage difficulties, like severe dyspraxia, things like that.
And how do these patients generally respond to PES? What feedback have you received from them?
So yeah, kind of variable feedback from patients in terms of what it actually feels like. I've had some patients who find it quite difficult to tolerate, and then other patients who were like, nope, I can go higher, keep pushing it up, I can go higher. And in terms of kind of what they say it feels like, I've had people say it feels like tiny pinpricks. Other people refer to it as like pins and needles. People describing it as a heat sensation and just kind of feeling vibrations in their throat. And then in terms of patients' responses to the outcomes of the therapy, I always try and get a quote from patients on kind of how they found the treatment. Tony, who I mentioned earlier, so he said, it was brilliant. It let me eat and drink again. It wasn't sore at all, just tiny little electric shocks. Honestly, when I had the treatment, everything changed. I could swallow again. I was so made up. I felt like I'd won the lottery. So it's a really nice statement. And then
that's lovely.
Yeah, other patients just saying, I'm really happy to have my swallow back. It's the best Christmas present for me. I can't wait to have my Christmas dinner, was another patient. And someone else said, I haven't had a thing to eat or drink for 9 weeks. My tongue was stuck to the top of my mouth. I'm so happy to have my swallow back. It's like a lot of things in life. You don't miss it until it's gone. So I think it's really kind of powerful feedback from patients. I don't think we can underestimate the impact of this in terms of quality of life. When someone comes in with a stroke, they obviously need immediate medical treatment, time is key, full workup, secondary prevention, but then it's over to us as therapists. And I think more people than ever are surviving strokes, thanks to interventions like thrombectomy and thrombolysis. But I feel like it's our job as therapists to make those people's lives worth living once they've survived a stroke. And I think eating and drinking is so intertwined with quality of life. Like it's not just about nutrition and hydration, although obviously that's important. I just think so much of it is kind of social and enjoyment and lifestyle. I think being nil by mouth is really life limiting. And I just think we need to fully understand that as clinicians and making sure we're doing everything we possibly can to avoid this.
You have already told us about your patient, Tony. Do you have another patient's rehab journey that you would like to share with us?
Yeah, there's lots of stories that I'd love to share with you, but I think the patient I'll chat to you today is a gentleman called Eric's. He's really happy again for me to share his story. So he is a 39-year-old man. He was admitted to the Mater in middle of November last year with sudden onset dysphagia, dysarthria, and neck pain. So he was diagnosed with an acute lateral medullary stroke. He had his initial SLT assessment on the day of admission, and then he had a FEES a few days later. So he presented with severe sensory motor dysphagia and poor secretion management. So he was requiring continuous Yanker suction at this point. His PAS scores were 7 on all consistencies trialed. So there was some kind of sensory response, but not sufficient to kind of the amount of secretions and the amount of residues. Like he didn't have kind of full awareness of those. So he remained nil by mouth, except for just ice chips. So he commenced PES about 14 days after admission, just as soon as the equipment arrived in the hospital. He had 6 treatments, which is the 2 cycles. And then I conducted a repeat FEES. So there had definitely been some improvement in his swallow function. So measurable things like he was able to manage his secretions a lot better. He was still self-yankering, but it was a lot less frequent. His PAS scores were now 3 on all consistencies, which was a big improvement. But there was still like moderate residues that were entering the laryngeal vestibule. So at this point, we started him on oral trials of 10 teaspoons of level 0 and just kind of 5 to 8 teaspoons of level 6 food, so soft and bite-sized food, 3 times a day. Although there had been some improvement, I definitely felt there was scope for more improvement. So we had a chat and Eric's consented to trialing another cycle of PES, which does kind of take it off license, but I know other places are doing that. So we repeated the FEES again 5 days after the 3rd cycle of PES, and his swallow was almost normal. So he was now fully managing his own secretions, no longer using the Yanker suction. His PAS scores were between 1 and 3 on all consistencies trialed, and the residues were now kind of classed as trace or mild. And he was an absolute trooper. Every time we were calibrating the dose, and I'd do the 8 seconds, he'd say, "Nope, I can go higher than that." So he really, really was invested in this treatment. He really, really wanted it to work. And he was delighted to get the outcome that he did. Towards the end of the treatment, he reported really, really significant discomfort in his throat. So when doing the FEES, I was kind of expecting maybe to see some edema or erythema. But as soon as we took the catheter out, there was no pain at all. So I think what he was reporting was actually just being really, really sensate to the catheter. There was no kind of structural issues or anything, no edema. So I
Which
think that was
is probably a good sign, isn't
it?
Yeah,
Definitely.
So you've been saying that one contraindication for you or in your hospital is that the patient isn't being transferred. Could you imagine, or would it be possible if you knew where the patient was being transferred to and if they're using pharyngeal electrical stimulation, that the treatment could be continued there?
I think in the future, that's definitely, something that would be possible. I think at the moment, the base station collects all the data for each patient, but we can obviously extract that data and input it into the patient's notes. But at the time, there were no other hospitals in Ireland, acute hospitals in Ireland, using the treatment. So it wasn't a case of being able to transfer them somewhere else for it at that time. But I think in the future, that could be a possibility.
Yeah, because I just feel like it would be a bummer if those patients couldn't receive it as early as possible just because they are planned to be transferred in 3 days or something. So that would be probably something good to make it more accessible to more patients.
Yeah, and we have had that before where there's a patient that we wanted to treat, but they were leaving the hospital.
And you've already said that choosing the patients wisely is really important to get the success or the positive outcomes. Nevertheless, have you had patients where PES did not improve the swallowing the way you were anticipating or hoping, or have you observed any adverse events?
In terms of adverse events, like it's probably worth noting that PES has now been used in over 5,000 patients worldwide with no serious adverse events. So we know it's safe, like it's CE marked and it meets the safety standards for Europe. It's also got FDA approval. But I guess kind of maybe minor adverse events would be things like possibly some edema. I've only seen once and don't know if it was necessarily related to the PES. So I haven't really had any kind of adverse events. I know, like from speaking to other clinicians who have used it, they've kind of noticed some things like hypersalivation, jaw chattering, things like that, but I haven't really experienced that myself. But yeah, you also asked, have I had any patients where PES did not improve the swallowing? So yeah, I can think of 3 patients where they didn't have kind of successful outcomes with PEG. And when I'm talking about successful outcomes, I kind of mean full return to oral intake rather than getting into kind of PAS scores and all of that. I'd say I probably spend more time looking at and evaluating the ones where it hasn't worked, because that's kind of where we learn, like it's an opportunity to then kind of get it right the next time. So of the 3 patients that didn't improve, so one of them, he was non-neurogenic, but he was like post-ICU. So he didn't have a neurological diagnosis, but he also had really kind of a poor baseline, really poor reserves, like a lot of sarcopenia. He went from being PAS 8 to PAS 7, so the sensation did improve, but it didn't have any kind of functional kind of carryover in terms of being able to safely commence oral intake. So that was one. And then more recently, we had a stroke patient who did have a sensory dysphagia, but as well as that, had very kind of dyspraxic characteristics of swallowing. And again, although the PES improved the sensation, it didn't actually help with the coordination of the swallow. That was kind of the main limiting factor. There was another patient on our respiratory ward with a diagnosis of COPD, and he was found to be at high risk of silent aspiration on video fluoroscopy. We searched for evidence in this cohort, and we decided to trial the treatment in the absence of any other therapeutic intervention being available after having discussions with him and the medical team. And unfortunately, there wasn't any significant improvement after PES. It's definitely like not for every patient. That's like it's saying that patient selection is really crucial.
Yeah, or at least sometimes you can improve some parts of the swallowing problem, which then can help to work on other parts. So it's not always, maybe we shouldn't always expect the return to full oral intake, but sometimes it's just one step in the journey of recovery.
I think it's very impressive that you've introduced this method in your hospital. And as you mentioned before, it was also the first hospital in Ireland.
Yeah, the first acute hospital, as far as I'm aware, there's a rehab hospital using it. But yeah, Mater became the first acute hospital, as far as I know, to actually start treating patients with it.
Well, congratulations for that.
Thank
For
you.
sure, that's impressive. What advice would you give to other clinicians who are considering integrating PES into their practice?
I'd say absolutely, like go for it. Like present the data to the relevant people in your organization, kind of order an evaluation pack and gain some experience in using it. Gather your own outcomes and your own patient stories, because I find that these hold more weight in terms of a business case when the studies are kind of inside your own hospital rather than a study from elsewhere. I don't know whether that's just because people have more passion behind it, or the hospital can kind of really see the potential for like cost savings and better outcomes in their hospital site. Also, just to know that it is safe and it's recommended in guidelines. The European Stroke Organisation and European Society for Swallowing Disorders recommend the use of PES as an adjunct to conventional dysphagia treatments in a paper published in 2021 by Rainer Divas et al. Also, NICE in the UK published guidelines on PES in January this year. They recommend PES for people with neurogenic dysphagia after stroke who have a tracheostomy in situ, and they consider the key efficacy findings to be quicker decannulation, reduction in the degree of aspiration, reduction in the severity of dysphagia, and also reduced need for tube feeding. They do suggest that more research is needed for other causes of neurogenic dysphagia, so it's really important for us to write up case studies and participate in RCTs, such as the FEAST trial, which Shaheen mentioned in your last episode. I really kind of see this becoming part of our kind of standard practice over the next few years. I just think with the evidence base behind it and the outcomes that I've seen, I feel like it just kind of has to kind of become part of what we do.
Excellent. Thank you so much. Thanks for taking the time and for sharing your knowledge, your clinical experience with us and our listeners today. Thank you.
Thank you for having me.
Thank you. Thanks so much for listening. We hope you enjoyed this episode. As always, if you would like to get in touch with us and stay informed about upcoming episodes, you can follow us on Instagram at Dysphagia Matters, on Twitter at DysphagiaPcast, or visit our website at dysphagiamatters.org. Take care, everyone.